Good morning and welcome to this YouTube video, and you can access me at www.painfreepartha.com in my website or in my YouTube channel Painfree Partha. So today's topic is about understanding cardiac output. This is very basic and most of us knew it but still I wanted to emphasize this topic for the basis of learners. Now, anything in academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, currently the director of Seed Dreams of Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth University, Pondicherry. So, what is cardiac output? Cardiac output is the term that describes the amount of blood the heart pumps each minute. 1 minute, how much of blood is coming out of the heart? This is cardiac output. What is that? How much time does it contract into? How much ml does it put in each contraction? So that is heart rate into stroke volume. One contraction, it gives 70 ml. It beats 70 times. So approximately it is 5 liters per minute. So is there a meaning to tell 5 liters for everyone? So it is not possible. So came the cardiac index. The cardiac index is the cardiac output 5 liters plus divided by body surface area. Then we can say around 2.5 liters per square meter. From 5 liters, the cardiac output can go up to 20 liters and in exercise, and even 42 liters are reported. Even you can see in normal labor, it goes up to 12 liters. So the cardiac output is normally a heart rate into stroke volume, which is 70 into 70, approximately 5 liters. And this is not very ideal. So we tell in terms of the word cardiac index, which is the cardiac output divided by the surface area of the person. And this is around 2.5 to 3 liters per square meter. If we want into the look at the other side of it, a person needs 200 ml of oxygen. How much he needs? 200 ml of oxygen. Now, 135 ml is the oxygen carrying capacity in anemic patients. So we need 1.5 liters at least. Here you see 1.5 liters. So, but clinically we need 2.5 liters per minute instead of 5 liters to avoid anaerobic metabolism. This is what you should understand. Now, if we go, already we have told heart rate into stroke volume is equal to cardiac output. Now, what are the determinants of heart rate and what are the determinants of stroke volume? Heart rate into stroke volume. Stroke volume is end diastolic volume minus end systolic volume. At the end of diastole, 140 ml is there. Now it pumps in 70 ml out. So 70 ml is there. So 140 minus 70 is stroke volume 70. So that is 50%. Then it means the ejection fraction is 50%. Leave alone all those things. Now the stroke volume is end diastolic volume. At the end of the diastole, around 150 ml is there or 140 ml is there, in which it pushes out 70 ml, then it means 70 ml is the stroke volume. Now, this heart rate is controlled by two things, autonomic nervous system and the hormones. Autonomic nervous system is divided into two parts. We know sympathetic and parasympathetic. We have a lot of hormones, especially catecholamines and thyroxine, all these things. We have atrial reflex going on to this autonomic nervous system. So these are all the things, and the heart rate is independently controlled by autonomic nervous system. But this atrial reflex, something is coming from here to control the heart rate here. Now we know heart rate, stroke volume. But sometimes the stroke volume or the determinants may control this heart rate by way of atrial stretch reflex. Now we know end diastolic volume and end systolic volume. Now what are the determinants of end diastolic volume? Preload is the most important thing. While also preload has a role in in systolic volume. So preload, contractility, afterload. These are the main three things in the determination of stroke volume. This preload is determined by venous return and filling time. Filling time means how much is the diastolic time. The diastolic time is decreased, so the preload automatically will get decreased. Now the autonomic nervous system contractility. Now you see stroke volume, heart rate. This filling time is determinant of heart rate. The autonomic nervous system controls heart rate and also contractility. So it is not that the heart rate are separately indicated, separately controlled by three things, and stroke volume is separately determined by three things. There is complete intermingling of these two essential factors, heart rate and stroke volume for cardiac output. You can see hormones for contractility. You can see vasodilators for afterload. Now, what is preload? We know this is catapult theory. No, we have one stone here, and just pull it up. The maximum you pull, the distance will be the maximum, and after that you pull. The this will tear. So if you pull maximum and then leave it, the stone will go to the maximum place. This is what is called the preload. If the preload is maximum, the contractility is maximum, and the ejection is good. So this is what is called the Starling's law. Ventricular end diastolic volume or the ventricular end diastolic fiber stretch. LV fiber end diastolic stretch is the catapult. So you just leave it as the stroke volume. The ventricular performance is very high. This is normal. Now this is exercise, normal exercise, but you have a heart failure here. See, if the ventricular diastolic volume increases, the performance is not that good. There is some problem in the heart, ischemic cardiomyopathy or something like that. So the performance is like not like this. So the cardiac output falls. So the fetal myocardial depression, you can have the yellow graph here. So this is the normal heart at rest, normal heart at exercise. This is some sort of heart failure. And if you give digoxin, the curve may go like this also. If you give inotropes, the curve may go like this also in a patient with heart failure. Now we have what is the catapult length? The left ventricular end diastolic fiber length, which is determined by end diastolic left ventricular volume. There the ventricular compliance matters. The LVEDP, left ventricular end diastolic pressure, and LVEDP. So here the LVEDP is proportional to LAP, left atrial pressure, only if the mitral valve is normal. The LAP, left atrial pressure, is okay with pulmonary arterial pressure only if the airway resistance is normal. The pulmonary artery occlusion pressure is proportional to PAEDP, only the pulmonary vascular resistance is normal. This is okay, RAP, right atrial, only with the tricuspid valve is normal. So the right atrial pressure determines CVP. And if the CVP is high, we think that your preload is high, and then you think, or if the CVP is low, you think you need fluids. But here you see, if the CVP has to correlate with the so-called catapult length, which is the ideal preload, then you have to have the tricuspid valve normal, pulmonary vascular resistance normal, airway pressure normal, mitral valve. If there is a mitral stenosis, then there cannot the CVP and the preload. If there is a severe bronchospasm, you cannot do this. So all these things, this is proportional to this is proportional to this is proportional to this, only if all these things are near normal. Venous return or preload. How much blood comes to the heart has to be pumped out, maybe over a period of time. Heart cannot store. Now you see, this is the preload as a venous return, and this has also got a filling time. So this is what determines the preload. An increased heart rate will decrease filling time, but stroke volume may not decrease with healthy hearts and exercise, but may decrease with electrically stimulated tachycardia. Pumping from muscles and skin, you see here, muscles and skin will increase venous return, thereby filling may not change in exercise. So, if you do exercise, tachycardia is there, but still there is a lot of pumping from the muscles and it fills. So, there is increase in the cardiac output because heart rate increases, the volume increases slightly, even though the filling time may be decreased. Now we know what are the phases of diastole. Protodiastole, ventricular relaxation, rapid filling, diastasis. This is what is heart rate dependent. Atrial kick is not going to be heart rate dependent. Rapid filling is not going to be. The slow filling time is decreased with heart rate increase. So then the filling is less if you have a rapid heart rate. What is Bowditch effect? Known as Kepi phenomenon is an autoregulation method by which the myocardial tension increases with increase in heart rate. Heart rate increases, the contractility increases. This is what is called Bowditch effect. Increased chronotropy will result in increased inotropy. This is the fundamental of Bowditch effect, also known as the Treppe phenomenon. This is only for certain things. If the heart rate goes up to 300, will it do? No. The output will come down, come down, come down. For some time, it will be okay. For slightly it increase. Then after that, it will come down. Now we know the end diastolic volume. What are the things? You see, hypovolema will decrease. Blood volume increase will mean filling systemic pressure. Venous pressure increases, pressure in the RA increases, venous return increases. The respiratory pump, suctioning, negative pressure increases the venous return. The skeletal muscle pump increases. The cardiac suction increases. The venous valves, they don't go back. Leads of venous vein is pushed into the femoral vein. This doesn't go back unless there are incompetent valves. So sympathetic vasoconstriction, all these things increase the venous return. This will cause an increased end diastolic volume. But if the fetus compresses the IVC here, then you get a block here and your venous return will decrease. So volume has to be ideal and your tone has to be ideal. The respiratory negative pressure pump has to be ideal. The skeletal muscle pump, all these things, venous valve makes the venous return. So these are the some of the factors which determines the venous return. And this venous return, how much is the venous return, is the essential thing about end diastolic volume. At the end of diastole, how much blood is there in the ventricle? That is around 140, 150 ml. Autonomic nervous system and the heart. Sympathetic is chronotropy, inotropy, and dromotropy. Parasympathetic is chronotropy and dromotropy. So this is because the autonomic nervous system is completely intermingled with the heart function. We have to know this because chronotropy, dronotropy comes with this, but sympathetic does inotropy. Two hormones of importance. I have already told you catecholamines and thyroxines. Now you see the venous return is increased. If the venous return is increased, the atrium is stretched. The stretch receptors, because more is coming to the right atrium. Venous return is increased. More is coming to the right atrium here. So, right atrium. So the stretch receptors are stretched. That causes an tachycardia. This is heart rate is increased because the atrium knows there is more amount of blood is coming, it has to work more. So that causes tachycardia. That is called Bainbridge reflex. But if the venous return is decreased, the stretch is less. So the right atrium, it doesn't need much contraction. So that is bradycardia. That is called inverse vein bridge reflex. That is the ideal cause of bradycardia following hypotension after little lower level of spinal anesthesia. So inverse vein bridge reflex. So venous return affecting atrial reflux, affecting autonomic nervous system and heart rate. What is ANREP effect? It's an autoregulation method in myocardial contractility which increases with afterload. If the afterload is increased, for example, a mild aortic stenosis, if there is hypertension, afterload, I'm coming back again after the afterload, what is that? Increase of the proportional ventricular inotropy. So long-term sustained afterload leads to concentric hypertrophy. You can see Kapil Dev, no? The right arm is big like this and left arm is little small like this because he's bowling like this. The muscle hypertrophy because it has to work more. And similarly, the left ventricle has to work more against hypertension, has to work more against a mild aortic stenosis. So it becomes hypertrophied. Afterload is a force against which the ventricles must act in order to eject blood, largely depend upon blood pressure and vascular tone. Afterload increase contractility. Afterload decrease causes better ejection. Otherwise, there is no direct relation. Now you can see this is going the LV length, blood is going to the aorta. If there is something pushing here, how the blood will go here? So an afterload increase will cause the cardiac output may decrease. But if the afterload decreases, the ejection is better. Okay, that is what is the implication of vasodilators in mitral regurgitation. Now, if vasodilators, if you give here, the afterload is decreased, the heart LV ejects better into the aorta than your regurgitant mitral valve. So that is the significance of afterload reduction in mitral regurgitation. So this is PR by T, stress pressure by radius, SVR, systemic vascular resistance, valve load, and systolic pressure. Pressure into radius by tension is equal to stress. Left ventricular stress is pressure into radius divided by tension. Plumbing in physics, simple vessel wall radius and viscosity, stress and pressure. The vessel wall viscosities. Now, I am going to tell in a different way. Preload is this, contractility is this, and afterload is this. If you are running the cycle downhill, your afterload is less, so you are able to better go inside. But if you are moving like this into the uphill, then your afterload is high and your output is less. So again, venous return, filling time, ANS, hormones, afterload, vasodilatation, wherein systolic volume, again stroke volume is better. If your stroke volume is better, cardiac output is better. Cardiac output into peripheral resistance is equal to blood pressure. Cardiac output into peripheral resistance. It depends upon how lumen and the viscosity of the blood. So flow into resistance is pressure. Resistance into flow is pressure. That is Ohm's law. Now we will go into some scenarios. Burns, ectopic diarrhea. What happens? There is a volume loss, blood loss, fluid loss. So what is there? Your venous return endosteric. See here, there is a hypovolemia. So decreased blood volume. So decreased venous return, decreased endosteric volume. So your stroke volume is less and cardiac output is less. That is how Burns, ectopic and diarrhea. So hypovolemia causes this cardiac output to decrease. Now here again, the cardiac output venous return is decreased. They still have decreased stroke volume. Decreased stroke volume has got a cardiac output. But there is a compensation of increased heart rate. Sometimes this increased heart rate can also decrease your filling time and preload. At increased heart rate can increase your contractility. That is Bowditch effect. Now you see there is a lot of interplay of physics and effects in this. simple diarrhea. Now, if you have a myocardial infarction, cardiac output decreases, but the decrease is due to a contractility decrease, not due to ANS. Muscle is gone, contractility is not there. So if the contractility is not there, it cannot pump out. The end systolic volume is high. End systolic volume, so 140 ml is there. It has to pump out 70-80 ml. So it is not doing that. It is doing only 40 ml. After the systole, again 120 ml will be there instead of 70. That is what is called the end systolic volume. Now it is 140 minus 110. It is 40 ml is the stroke volume. Then your cardiac output is likely to decrease. This is what is the essence of myocardial infarction. Hypertension and aortic stenosis. You see a pipe here. Water is flowing from here. Now, if there is a small aperture here, it cannot go. This is what is called afterload increase. So your force is not come. You have opened out. Everything is, your preload is fine. Your contractility is fine. But still there is a small obstruction in your tube pipeline. So your flow is not good. Your cardiac output is not good. That is what is the problem of increased afterload. So you go into anemia and cardiac output. What happens in anemia? Anemia, heart rate increases. So heart rate is increased 1 point. But here you can see in the anemia causes viscosity to decrease. It becomes less viscous. So viscosity and lumen forms the afterload. Decreased viscosity will cause decreased afterload. This decreased afterload, automatically your bicycle is running downhill, the cardiac output will increase. So these are all the two things which happen in anemia. You increase the heart rate and your afterload is decreased. So all these things sometimes causes, if it is severe, they are going to cause high output cardiac failures. Now, if you go to hypothermia, hypothermia will decrease heart rate, hypothermia will decrease contractility. So sometimes if it is going to be severe, then your cardiac output is going to decrease. Because your end systolic volume increase, your stroke volume decrease, automatically your cardiac output is decreased because your heart rate is also going to decrease. Now you have Paget's disease and AV fistula. AV fistula means what? Directly it is going from artery to vein. So the complete reduction of afterload. There is complete reduction of afterload. If the afterload is decreased so much, the cycle is coming downhill. It is easy. The output increases. The cardiac, these are all cardiac high output diseases. Now, if you have a thyrotoxicosis increases heart rate. So increases cardiac output, but also causes better contractility, increases stroke volume. There is a decreased afterload also. You see, the difference between high output of thyrotoxicosis and high output of anemia. High output of thyrotoxicosis is associated with better contractility, but in anemia, heart rate and afterload decrease. But here you can see the contractility also increases because there are two hormones. One is catecholamine, another is thyroxine. These two play in cardiac output. So that is the difference between high output of thyrotoxicosis and high output of anemia. Now, if you go to sepsis, the contractility is slightly depressed, but there is a vasodilatation. Your systemic vascular resistance will decrease. Again, the cycle is going downhill. The afterload is decreased. The cardiac output may be increased, but in severe sepsis, sometimes the contractility is so much depressed, even though this thing is there, the BP starts to fall. Pulmonary hypertension and RV dysfunction are different entities in sepsis which are not considered now here. Till now we are talking about LV. Your cardiac output is LV. Now what is the difference between LV and RV? Heart rate is same. Stroke volume is same. But what is the difference? So heart rate into stroke volume, cardiac output is same. But what is the difference? Systemic vascular resistance is high. PVR is low. The RV needs to contract a little less only because your resistance, you are going downhill in RV. But the pulmonary vascular resistance is LAP matters, here RAP matters. You see the difference between LAP and RAP. So what you need, you don't need that much contractility to get the same stroke volume as LV and same cardiac output. Now you see aortic is 120 by 80 and LV is 120 by 5, while in right ventricular it is 15 by to 25 only. Pulmonary pressure is only 8, 15, 25, 8 by 50. So Frank-Starling's law we have told, Bowditch law we have told, the Andrup effect we have told. Preload, contractility, and afterload. The heart rate is dependent upon autonomic nervous system and hormones. Heart rate into stroke volume is cardiac output. The heart rate is controlled also by the venous return by way of Bainbridge reflex. The heart rate influences filling time by decreasing the diastolic time, especially diastasis. The preload decreases means your stroke volume decreases. And the autonomic nervous system is directly involved in contractility. The hormones are directly involved in contractility. If you have a decreased afterload, yes, it is better for the cardiac output. If you have an increased cardiac afterload like hypertension, aortic stenosis, yes, this has to work more and there is an LV hypertrophy to achieve the same stroke volume. Overall assessment of cardiac output is in simple terms the urine output. Thank you all. Thank you very much for your patience.